Let's see, where should I look so that the Zoom people feel like I'm looking at them? Up there, okay. Thank you very much for that kind introduction, and it's great to be here. I had a chance to talk to Dr. Fahn this morning about some really interesting research. It sounds like that's going on here at UMass that has to do with helping people with serious mental illness with their health and fitness. So hopefully this will be of great interest to you folks. So I'm going to talk a little bit about obesity and sort of the problem of obesity in this country and around the world, and just kind of give a little bit of background and rationale for why it's important that we've developed tailored fitness programs for people with serious mental illness. And then I'll present some of the research on evidence-based fitness promotion programs, and then specifically focus on a program that I've been involved with for the past almost 20 years, which is called the InShape program. And that's actually a program that Community Health Link implemented several years ago, but it was not sustained there. But anyway, I'll get into talking about what that one involves. So this slide basically just shows that overweight and obesity, the proportion of the population in the US who are either overweight or obese, has increased over the decades. And you can see in particular the bottom chunk there is people who are overweight but not obese. And then the darker green are people who are in the obese categories. And that's really where we've seen a lot of the increase. At this point, almost 70% of adults in the United States are either overweight or obese. And you can see that about almost half of those are obese or in the obese category. And, you know, this is true around the world, unfortunately. This is not just a problem in the United States. Worldwide obesity has nearly tripled since 1975. And I mean, the point on this slide that to me is sort of the most shocking is that most of the world's population live in countries where overweight and obesity actually kills more people than starvation and being underweight. So that's not a great state of affairs. And this is just a slide that shows the colors, so that the darker reds as compared to the lighter yellows indicate a higher percentage of the population in that country who qualify as having obesity, who have a body mass index greater than 30. So you can see the US, you can see South Africa, you can see Saudi Arabia and Libya and Venezuela, but you know, those are all countries where more than 30% of the population have obesity. And then, you know, of course, you can see in Africa, not surprisingly, it's less than 10% of the population has obesity. So it obviously varies across the world, but it is a worldwide problem. China actually has overtaken the US as the most obese nation, although we still hold the top spot for the highest proportion of people who have severe obesity. And, you know, why is this? Why has this happened across the globe? I think environments are not set up. The more developed a nation becomes, the less the environment is really set up to promote movement and healthy eating, right? We sort of develop, you know, environments where we have to drive around to get to places versus walking. You know, developments in food processing and distribution just lend themselves to unhealthy eating versus more healthy eating. And the obesity problem among people with serious mental illness is much worse. So whereas in the general population, the percentage of people with obesity is, you know, anywhere from 30 to 35, it's 66% in people with serious mental illness. So twice the rate as the general population. So that's alarming, especially in the context of, I don't know how many people have heard about this research that was done that was looking at mortality risk by weight category. So it looked at people who are underweight, people who are normal weight, people who are overweight, and people who had obesity, and found actually that there was a lower mortality risk for people who were just in the overweight category but were not obese. So you can see for people with serious mental illness, because they were controlling for age and sex and smoking and illness diagnosis, but you can see how this creates an even more alarming picture for people who have serious mental illness, because the majority of those folks are in the obese category. And so they're very much at risk for early mortality. I know this is a little bit small, so I apologize. But why is that? Why are people with serious mental illness? Why do they have twice the rate of obesity as the general population? We know there's illness and treatment-related factors. So negative symptoms can make it difficult for people to move. Depression, as we've seen in our research, sometimes even makes it more difficult than negative symptoms. Executive dysfunctions, lack of money to pay for fitness resources, anxiety, paranoia, all those kinds of factors make it difficult to engage in exercise in particular. Sedation from medications, the impacts on satiety and insulin resistance, particularly for antipsychotic medications, obviously make it more likely for people to become obese. But there's a large collection of literature showing that there's just low engagement in regular exercise, that people with schizophrenia in particular do not consume as many fruits and vegetables, and just end up consuming more sugared beverages and high carb foods. And anybody who worked with this population has seen that, of course. There's also some research, although I think we need to have a lot more, about potential biological factors. So there's been some studies looking at leptin, which is a hormone involved in appetite, in BDNF, a protein that's expressed in the hypothalamus that's involved in appetite. So other kinds of factors that could use more research and may be involved in this problem in this group. But what we do know, whatever the cause, we do know that people with serious mental illness have much higher risk for cardiovascular disease. So abdominal obesity in particular, 4 times the rate. We know that people with serious mental illness smoke at 3 to 4 times the rate in the general population, twice as much diabetes, probably about 1.5 times as much hypertension or more, metabolic syndrome 2.5 times, et cetera. And so this has caused, kind of an epidemic of premature death in people with serious mental illness. The average life expectancy is about 53 if you have a serious mental illness, which is about on par with the life expectancy in Ethiopia. This is a slide from, and we've known this for a while. This is a slide from a study that was done in 2006. And they looked at multiple studies conducted in multiple states over multiple years, dating back to the late 1990s. And this shows the gap in life expectancy between people with serious mental illness and people in the general population. So it's not an idiosyncratic finding. It's been a consistent finding for a long time, and we've known about it for a long time. So you can see, up to high of 32 years of gap between life expectancy. And this is a slide this is a little bit hard to read too, but what this slide shows, and this is from the same study, is that early mortality is caused by cardiovascular disease. That's the primary reason why people with serious mental illness do not live as long. It's not about suicide. It's not about, quote unquote, unnatural causes of death. The white bar that you can see under each one of those studies is cardiovascular disease. So that is standing out as the primary cause of premature mortality. And unfortunately, that mortality gap has been increasing over recent decades instead of decreasing. So as much as we know this is a problem, it's a problem that unfortunately has been getting worse instead of better. And it's not a problem. This is not a problem that's unique to the United States either. So there was a study done in 2015 that looked at 29 different countries over 6 continents and found that mortality risk for people with serious mental illness was more than 2 times that of people without a mental illness. So this is a problem that's worldwide as well. And what do we do about it? Well, one thing that we know is that if you look at determinants of health, healthcare is important, But it turns out that's really only responsible for like 10% of variation in health. The major factor that determines difference in health is lifestyle practices. So 51% of what determines your health and what distinguishes one person from another is lifestyle practices. So that's where the focus needs to be. You can see smoking, obesity, nutrition, drug use, et cetera. So that's where we focus our attention. And I have felt for decades, I've been at this for 20 years, that mental health professionals really need to kind of take a leap of faith. If we keep doing things the way we have been, nothing's going to change. If nothing changes, right? And so we have to kind of take this on. It's, people with serious mental illness have not had a good experience in primary care. Primary care hasn't taken great care of these folks. And there's certainly been an acknowledgement that, the mental health system needs to be willing to consider people as whole individuals, mental and physical health together. And so so we've recognized since the 90s that, there's this huge health disparity for people with serious mental illness. And in the early 2000s, you start to see this development of fitness models specifically tailored for people with serious mental illness. And then in 2009, SAMHSA, which is the Substance Abuse and Mental Health Services Administration, established a program called the Primary Behavioral Health Care Integration Program. That program has funded over 200 community mental health centers around the country to integrate primary care into mental health. And I've served as a consultant and evaluator on 4 of those projects and dealt with some resistance from mental health professionals. Oh, I don't know, this is outside my scope of practice, or like psychiatrists who say, I don't think I can take a cholesterol. It's sort of like, I'm pretty sure you went to medical school, so this is not rocket science. But there's kind of been this resistance about taking this on and really embracing the idea of integration. And integration is beyond co-location. Co-location is great, but man, if you can have integration, that's even better. If you can have one provider who kind of gets it and is willing to consider the mind and the body, all the better. So there's only really been a small number of fitness promotion programs that have been developed and evaluated and have some evidence for people with serious mental illness. And so I've listed them here, and I'm just going to kind of go through them one by one. So STRIDE is a program that was developed by some investigators at Kaiser Permanente out west. And this is a program specifically for people taking antipsychotics, responding to the problem of antipsychotics affecting satiety and causing a lot of weight gain. It's based on the DASH diet, and it involves weekly group education and weekly group exercise. So it's basically like bringing people into the clinic, giving them education about healthy eating, and then the exercise was primarily like walking. And there's a standard curriculum, a manual, and handouts. These are the topics. This is some of that. There's a lot of great topics. I've actually used this curriculum in an inpatient setting that was interested. The state hospital in Concord, New Hampshire was interested in doing something about fitness promotion and kind of like the idea of running people through this curriculum. So I have so there's some really good topics, I think, that are included, but you can see most of them have to do with healthy eating versus exercise. So the focus is very much on healthy eating, and there's less of an emphasis on exercise. These are the other topics. There's a different topic every week for 24 weeks. And it's been subjected to several randomized controlled trials, including sort of their main study where they enrolled 200 people who had a body mass index over 27 and were recruited from community mental health centers out west. People got randomly assigned to either STRIDE or usual care for 12 months. And they did find that the STRIDE participants lost more weight, actually 9.5 pounds more than the usual care group at 6 months. And then by 12 months, that had kind of the STRIDE folks had caught up a little bit more, and the difference wasn't quite as strong, but they still found a significant difference between the two groups. The ACHIEVE program is developed by Gail Dommett and Jerry Jerome. They're at Hopkins. This is an 18-month intervention. It involves healthy eating educational sessions weekly, and group exercise week. Well, they're 3 times a month, I should say. So they come in every week. 3 of those weeks is for the group exercise and eating education, and 1 is for an individual meeting once a month. And they do that for 6 months, and then for 12 months, they come in. They have only 1 education session, and they have 3 exercise sessions and the 1 individual meeting. So it's pretty intensive. They published a study where they enrolled 291 people who received either ACHIEVE or just quarterly health information groups. This was a very overweight group. The mean baseline BMI was 36. And they found a significant difference in weight loss favoring the ACHIEVE group over 18 months. But you can see the percentage of people in the study who lost more than 5% of their body weight, which is considered clinically significant weight loss, was relatively small. Basically, the ACHIEVE group, it was almost 38% versus the control group was 23%. And then there's an intervention called the Peer-Led Group Lifestyle Balance. It's a 12-month intervention adapted if you keep tracing it back from the diabetes prevention program. This is weekly group education, mostly on healthy eating, in supported housing for 3 months, weekly groups, then bi-monthly, so twice a month for 3 months, and then monthly for another 6 months. And they enrolled 314 people and randomly assigned them to get the intervention or not, and did not see any significant differences between the groups on clinically significant weight loss. And their percentages were about, at 6 months, they only had about 15 to 17% who had lost more than 5%. By 12 months, it was up to around 25, and by 18 months, they did an 18-month follow-up that was maybe around 30%. So it's still kind of a small percentage. So then lastly, the InShape program. This program is quite different. It's a program that was specifically designed for people with serious mental illness. And it's weekly individual meetings. So this is really, it stands out because it's not a group-based program. It's individual meetings, and it's with a certified fitness trainer. So this is where mental health centers hire a certified fitness trainer, and we refer to them as a health mentor. The mental health center also makes sure that participants have access to either free or low-cost gym memberships, establishes partnerships, community partnerships with other fitness facilities and resources. And then the program offers quarterly, quote unquote, celebrations, which is the only opportunity. Well, they offer, different programs offer a variety of different group activities as well, but this is a chance for the whole community to come together and sort of highlight and celebrate successes of participants in the program. And this is Ken Ju. He's the creator of the program. He unfortunately passed away in May, very precipitously and unexpectedly, but he created the InShape program in 2003 with funds from a Robert Wood Johnson Foundation grant, and started partnering with me and my group in 2004. And we've done multiple studies to evaluate the program. And I've also worked with him for years as a trainer and a supervisor, working with community mental health centers that are not part of research, but are interested in implementing the program. And this is a quote from Ken: "People experiencing mental illness die on average 25 years younger than the general population. It is morally indefensible to accept the status quo and do nothing to alter this situation." And he, when he used to talk about the InShape program, would talk about how he started noticing he was going to, as a CEO, he's going to all these funerals of clients at the mental health center who were in their 40s and 50s, and just said, this is not right. We have to do something about this. So that was his inspiration for developing the program. And he was just an incredibly energetic, creative person. And this was just a huge passion of his. So the sort of core philosophy of InShape, I think, is also a little bit different from some of the other fitness promotion programs. InShape is definitely a recovery-oriented, person-centered program, and social inclusion is sort of one of the pillars of InShape. If it doesn't have social inclusion, it's not InShape. And community engagement and partnerships are also kind of one of the core features of InShape. So how is it recovery-oriented and person-centered? People develop individually tailored exercise programs. So it's not about everybody as a group doing the same exercise or going for a walk or whatever. It's working with a certified fitness trainer to come up with your own individually tailored exercise program and healthy eating program. The health mentors get training from a nutritionist who actually is at BU, who's a PhD nutritionist, and has a program that really emphasizes the role of habits in healthy lifestyle behaviors. So it teaches people about the fact that we're creatures of habit. If you think about it, most people, you kind of like eat the same things every week, maybe even every day. And it's not because you go into the grocery store and think, I have no idea what I'm going to buy. What should I, you're just used to like going to your spots, picking up your thing. I'm a mom, like my kids, it's like, oh, when are we having salmon this week? It's like the routine. There's like a certain slate of things that I'm going to prepare during the week. So it's like, I'm just in the habit of preparing healthy food. And if you're in the habit of not eating healthy food, it's not because you're sitting there saying, oh, I think I'll eat things that are going to make me overweight. I think I'll eat these things that I know are bad for me. They're just in the habit. You're just in the habit of it. And a lot of habits come from childhood, and habits, are just sort of automatic. So I like the approach. And I think it's really effective to teach people about, it takes the shame out of people who do a lot of overeating to recognize, I'm not doing this because I'm stupid or I make bad choices. I'm just doing it because this is what I've gotten used to doing. So anyway, the goals that people have are set by the participant, and there's a real emphasis on big picture goals. So it's not just about, losing weight. People come in, you say, what are you hoping to get out of the program? Well, I want to lose weight. And it's like, okay, but weight loss is in the service of living into a better life. It's not just about getting on this little square that a number pops up and it's like a smaller number when you step on. It's like, how is being lighter, how is losing weight going to impact your life in some kind of positive way that's really desirable to you in the context of your life and what's important to you? So that's a huge focus for InShape. The social inclusion piece is really huge. If the fitness trainer is not working with people in the community, in community fitness settings, it is not InShape. If they're in the basement of the mental health center, it's not InShape. InShape is meant to bring people who are marginalized, who, don't have a lot of experience, maybe being in community settings, find it potentially anxiety provoking, or feel like they experience a lot of stigma in those places, to feel like they're part of the community, feel like they're accepted, experience a sense of belonging. And, that has a halo effect, right? So then it's not just about weight loss. It's more about feeling like I am a respected person who has dignity in this community. I'm involved in activities that I chose, that I want to do, but that are in places where everybody else, pursues fitness. Because what we know is that disadvantaged groups in every country, there's disadvantaged, excluded groups in every country, they experience a lot of health inequity. And the COVID pandemic has probably highlighted that a lot for us, right? Community partnerships is a really important part of the program. And it's really about reaching out to a community, challenging them to accept their responsibility for the health and well-being of everybody, whether they have a mental illness or not. And Ken was just masterful at leveraging, common goals that organizations would have and figuring out ways for them to come together to support the program and for the program to benefit their organization. So it wasn't all about what can you do for us? It's like, here's what we can offer you, and we can work together to improve the health of everybody. So Ken had partners like the YMCA, Keene State College, Department of Health Sciences and Nutrition. There were, nutrition students that needed internships, and it was like, wow, here's an opportunity to work with real live people who need nutrition education. Had partnerships with lots of different fitness places, dance companies, and karate studios and things like that, dojos, and on and on and on. A lot of university connections for research purposes and interns who could serve other functions. And so InShape has become really the most widely implemented fitness promotion program for people with serious mental illness. We have implemented it in 80 community mental health centers in 28 different states. Unfortunately, it doesn't exist in all 80 of those anymore. It's hard for agencies to implement and maintain fitness promotion programs. And I'll talk a little bit about that later, but it's certainly something that has been implemented very broadly. So I'm just going to quickly go through some of the research on InShape and then talk about some of the lessons learned and some of the challenges. So we started off with a pilot study. It was money that we got from a local foundation. It was a 2-year award. We enrolled 98 people and just had a pre-post design. We found that we were able to significantly increase hours of exercise. And you can see a lot of that happens early on in we call it the honeymoon phase, that first 3 months where people are like really excited. So it kind of tails off a little bit. And it was a lesson learned about, how do you maintain that enthusiasm? Waist circumference, we saw a significant decrease. So that abdominal obesity, that's really important to decrease. We saw increases in self-efficacy, and that we used a measure that looks at social self-efficacy. So, how confident are you in your ability to shake hands when you meet somebody? In negative symptoms, self-efficacy for negative symptoms, overcoming them. How confident are you in your ability to go out and do something even if you don't feel like it? And so it had this kind of spillover effect and ability to sort of motivate people, get them activated in the larger community versus just related to fitness activities. We actually saw negative symptoms significantly decrease, which is really hard to do. And again, I think it's that sort of like activating nature of the intervention. So those data were good enough for us to apply to the Centers for Disease Control for a randomized controlled trial. And this was in Concord, New Hampshire at the local YMCA and with the local mental health center. We enrolled 133 people, and they were randomly assigned to either receive the InShape program, including a free gym membership, or the free gym membership alone. And we published our findings. What we found was that at 12 months, a significantly greater percentage of people who were in the InShape group achieved either clinically significant increased fitness, which was defined as more than 50 meters improvement on the 6-minute walk test, or clinically significant weight loss. So the InShape is the black bars and the comparison group is the white bar. So you can see they're outperforming them at each of the time points. And these are some slides just showing we administered some measures of stage of change for eating habits. So dietary fat consumption improved for people in the InShape group. They're the blue bar, that's improvement. Consuming more fruits and vegetables improved. It kind of leveled off. Again, you can see maintenance is important. But almost simultaneously, we also applied for an R01, which is a large randomized controlled trial from the National Institute of Mental Health, and conducted a similar randomized controlled trial where we enrolled 210 people who again received either the InShape program, which included a gym membership at one of the many area YMCAs in Boston, or gym membership only. And we partnered with VinFen, which is a large provider of mental health services in Boston, and Bay Cove Human Services as well. And we published we had basically similar findings that you just looked at with our CDC project. So significantly more people in the InShape group achieving either clinically significant weight loss or increased fitness. And then we had an opportunity to apply for a $10 million grant from the Centers for Medicaid and Medicare. There was a program called the Medicaid Incentives for Prevention of Chronic Disease. And for us, the goal was to reduce cardiovascular risk in smokers and people who are either overweight or obese, who were clients, service users at all 10 of the community mental health centers in New Hampshire. We partnered with all of them. And we offered 4 different weight management programs, 2 of which contain the InShape program, and 3 smoking cessation programs. And this was an equipoise stratified randomization design, which basically means people had some choice as long as they were willing to be randomly assigned to at least 2 of the options. So if you were in the weight management group, you could say, I don't like this one or that one. I'll be randomly assigned to one of the other 2, or you could be randomly assigned to all 4. And same with the smoking cessation programs. You could eliminate one from the running, and as long as you're still willing to be randomized. And so what we ended up with was 1,350 people who enrolled in the weight management program, and 1,100 of those people received InShape. So you can see InShape was really popular, and people actually knew how to game it so that they would be guaranteed to get InShape, because the 4 groups were just a fitness club membership for 12 months, the InShape program alone, which included the fitness club membership, but also working one-on-one with the fitness trainer, a Weight Watchers membership for 12 months, or InShape plus Weight Watchers. So you can see how to game it so that you definitely get the InShape program, right? You say, well, the only 2 I'm willing to be randomly assigned to are either group 2 or group 4. You're getting InShape. And that's pretty much what people did, because 1,100 out of the 1,300 ended up getting the InShape program, which kind of means that the equipoise stratified randomization didn't really work very well. But it also told us how appealing it was for people with serious mental illness to be able to work with that fitness trainer. I mean, that was what we learned from that, is that they want the InShape program. What sets the InShape program apart from groups 1 and 3? They have this certified fitness trainer that's going to work with them and meet with them every single week on their fitness. So the way the study worked was that after people were randomly assigned to one of these 4 groups, they were then simultaneously randomly assigned to either just get the program that they were randomized to, or earn additional incentives for participating in those programs. So people who were randomly assigned to the fitness club membership, they could earn $5 each time they went to the gym, up to 3 times a week. And so anyone who had a gym membership. So that was true for group 1, for group 2. So people in the InShape program, if they went to the gym without their health mentor, we knew they'd go with their mentor. So the only way they could earn money for going to the gym was to go without their health mentor. But they could earn $5 every time they went without their mentor. The Weight Watcher group could earn $10 for going to 1 weekly meeting, because that's sort of what's prescribed in the Weight Watchers program. And then the people in group 4 could earn that $10 and also that $15. And they could earn that every week for 52 weeks. So there was a fair bit of money on the table. And this is kind of what people looked like at baseline. It was mostly women, 2/3 women, which kind of maps onto just the population of outpatients at these community mental health centers. they tend to have a higher percentage of females than males accessing their services. There was a good split among like schizophrenia, bipolar, major depression, and then anxiety disorders. You can see that about 30% of people had diagnosed hypertension, but then another more than 40% had pre-hypertension. Over 30% had a BMI at baseline that was more than 40, which is like really severely obese. The smallest group was those who were just overweight but not obese. Only less than 20% were in the 25 to 29 range. So most people, 80% of the folks were in the obese category. And what these slides show, which I found kind of interesting, is, because we have this, preconceived notion that it's especially people with schizophrenia that are at really high risk, right? And what this showed was that actually at baseline, if you look at sort of the proportion of the red versus the orange and yellow and white, the people with major depression actually had the highest, and anxiety disorders, the highest percentage of people that had a BMI over 40. So it was a little more balanced in the schizophrenia group. You can see how the blocks are kind of similar. So I thought that was kind of interesting. And it bears out in exercise capacity. So lower is worse. So the people with major depression, their ability to do the 6-minute walk test was very low compared to the other groups. So it says to me, we shouldn't be just focusing on people with schizophrenia. It's a broader group of people with serious mental illness. And depression in particular, I think, is something that causes such a motivation that it's a huge risk factor. I'm sorry, I know this is a little bit tiny. What this is showing is if you sort of put side by side the group that received incentives for participating and those that did not, the ones that received incentives outperformed the group that did not. So if you look at the Weight Watchers monthly down at the bottom, so the red and the orange. So the red is the people who got the Weight Watcher membership. Only the orange bar is the people who additionally received money for attending Weight Watchers. So, and this is just participation. This is just, did it make them go more? And it did. So if you pay them, they will go. And for example, in the middle of the gym, except for the gym only, that's the white and the gray bar. They're basically the same. So it really didn't help. If people didn't have the health mentor involved, it really didn't help to pay them to go to the gym versus not pay them. None of those people, went to the gym as much as people in the other groups. So the pink and the purple is the in shape versus in shape plus the money. And then the kind of light blue and green, that's the in shape plus Weight Watchers plus money versus in shape plus Weight Watchers alone. So it does help, except for the gym only group, it does help to pay people in terms of their engagement. And then what this slide shows, this is weight change. So if it's going down, it's better because that's more weight loss. The two groups that have Weight Watchers perform better than the two groups that do not have Weight Watchers. I mean, this really illustrates that you need both. You have to have exercise and healthy eating. So exercise alone is the gym group at the top. In Shape really focuses heavily on exercise. So then if you add in Weight Watchers, which is obviously a very intentional, tracking what you're eating and focusing on your calories or your points, you get an even bigger bump in terms of weight loss. And I didn't include this one, but the group that performs the best is the group that had In Shape, Weight Watchers, and the money. So that's some of the research we've done. We've also, I didn't focus on, we did a large randomized control trial that looked at how to implement In Shape effectively. And we compared, we had 48 sites. These were all mental health centers around the country, and they were randomly assigned to either get the in-shape training and then get sort of individualized technical assistance, or get the in-shape training and participate in a learning collaborative as a way to try to sustain the program. And we've just submitted a proposal to the National Institute of Mental Health to evaluate sustainability. So now that project has been over for 5 or 6 years, and we've sort of gone back to look at, all right, which of these agencies managed to sustain the program? And unfortunately, Community Health Link did not, but lots of others did not either. It sort of looks like initially that about 55% of, or 60% roughly of the sites that were in the learning collaborative maintained the program, as compared to about 40% of the agencies that did not participate in the learning collaborative. So, but we'll see whether this gets funded and if we get to kind of look at this. I mean, it's an important question. You know, it's one thing to put all the work into implementing a program, but you want it to stick around, right? So there's been lots of reviews at this point of research on fitness promotion. And these are some of, there was a review that SAMHSA sponsored in 2016. There's been other reviews published since then, but these are kind of the lessons learned from these reviews. One lesson is that fitness programming really is appealing in this group. It's not that hard. We've done research, and I have different branches of my portfolio, as was pointed out by Dr. Fawn, and this is not a tough one to recruit for. People sign up and you can fill your slots pretty easily. People are interested in working on their fitness. And with intensive support, people can make health behavior changes. We've had people in studies lose 50, 60, 70 pounds. I mean, it's possible. The combination of exercise and healthy eating is what has been optimal and what has led to better outcomes in research. So both of those factors are really important. And I personally think that the support for change in healthy eating habits has to be core, and not just educating people. You can't just teach people, what they ought to be eating, what they shouldn't be eating. It really has to be like weekly support where you help people to set action steps around their eating habits and then review them and then set more, review them. Education alone really doesn't work. And intensity matters. The research, these reviews of the research have shown that, a 6-month program is better than a 3-month program. And if you think about the changes that need to be made to produce outcomes like weight loss, those are not things that you can do for 12 weeks or something. These are changes that are hard. They take time. And, I get it that that's sometimes not appealing in mental health, but intensity does matter. But there's challenges. And really one of the take-home messages of these reviews of the research is there isn't any magic bullet. It's not like, oh, here's the one thing that, works in all cases. It is tough to get clinically significant weight loss in a large proportion of participants. So your expectations have to be lower for how many people are going to achieve clinically significant weight loss. I think we need more research on potential biological correlates of weight gain. I think that would be really interesting. And it sounds like your group does a lot of work where you're kind of cross-cutting between biological and more psychosocial. Organizational commitment is just so key. And I think we will find that and illustrate that if we get this grant and really get to dig into what predicts whether sites were able to sustain the program or not. But the other big challenges are financing and policy. And I have found that over my 20 years of work in this area that, funding for fitness promotion is really challenging in mental health. And we had to fight really hard in New Hampshire to get our Department of Health and Human Services and the commissioner to agree to allow certified fitness trainers to be hired and bill for services in the context of a mental health center. I mean, you'd think it shouldn't be that big of a deal, but that's a huge barrier. So, and I published a white paper that people can find that talks about the policy changes that are really need to offer fitness promotion widely. And incentives are a whole other ball of wax, right? That's really hard to achieve, even though we've proven that incentives work. That's like way out there, right? Who's going to pay for it? That's it. I want to give some time for questions.
Thank you very much. Reminder, people on Zoom can ask questions in the chat.
Yes.
Hold it. People on Zoom can't hear.
Thank you for the talk. I was wondering, did you try any of these interventions in people who were not overweight, and if it had a benefit on their mental health, like not focusing on weight loss, and then also besides self-efficacy, did you look at any other outcomes?
Like mental health outcomes?
Right.
Yeah.
Endorphins, right?
Yeah. No, that's a great question. The original program did not require people to be overweight or have obesity. As it turned out, only about 13% or so of those 98 people were either normal weight. I don't know that any of them was underweight. There might have been. I mean, most people with serious mental illness are overweight or obese, the majority. So as we've implemented the program and gotten questions about, well, who is this for? Who should we offer it to? We kind of like, well, it's such a high demand program. You kind of like want to offer it to people who are really at risk and really need it. People who are fit and have figured out how to maintain a healthy weight don't need it as much. But that being said, we always kind of say, but it's up to the individual agency. In our studies, we can obviously impose certain inclusion criteria, but part of that is about just, we want to demonstrate change. And if someone starts off at a healthy weight, we wouldn't expect them to lose weight. If weight's the primary outcome, you really have to require overweight for entry. But your point is a really good one. There are people who are normal healthy weight, but just may not be that fit. They don't exercise very much, and certainly exercise is recommended for anybody and can have, there's a long literature showing that, exercise can have mental health benefits. We probably need to look at that a little bit more in our own data. We have collected some mental health outcomes. Our focus has been more on decreasing risk for cardiovascular disease, but that's a great point.
I appreciate your comment about people who suffer from major depression, because obviously people who are seriously depressed would have a hard time losing weight or stopping smoking or exercising, all of which would be good. Right, until you get the depression better. So it's kind of a vicious cycle.
Yes.
But the other interesting thing is that there been studies that people with high BMIs don't respond to antidepressants as well as people. And I don't know if that's true in psychotic disorders or schizophrenia, but if it's not known, maybe somebody should look at that.
Yeah, so maybe I will make a few comments. Yeah. So first of all, the question you asked, and so in terms of mitigating metabolic comorbidities in patients with schizophrenia, there are two types of strategy we're talking about. One is the preventive strategy, another one is the intervention strategy. So preventive strategy, I think in psychosocial intervention, probably we focus more on intervention approach. In other words, when metabolic problem like obesity already happened, but in pharmacological interventions, we do in the literature, even some study I was involved. Yeah, there's kind of a preventive strategy. So, for example, when you start a patient on olanzapine or coladrol, we know those medications carry high risk and metabolic risk, right? So we will preventively add like a metformin together, so as a kind of preventive measure. So that's kind of preventive strategy. Now, I think Tony, you just mentioned there is a kind of phenomena, at least in patients with in schizophrenia research, that those people. I think maybe 10 years ago, there are more, a few studies suggest that there's a correlation between metabolic risks and good therapeutic response, like a mental and like psychotic symptom aspect. So, but then, then an argument saying this is probably an EP phenomena. It's just like there's no real relationship. But in recent years, we kind of shift away from that argument. Yeah.
Well, the speaker has to attend a study section at 1 o'clock. So if there's no other questions, I think we'll stop. But thank you. Thank you very much.
Thank you very much.
Thank you.